Thank you. Here's my disclosure. There are many potential failure modes in EVAR and parallel endografting, and in interest of time, I'm going to focus on the first two. I'm also going to discuss a novel system to evaluate aortic anatomy and guide therapy that I call the point of reference system. Unfortunately, it's only been published so far on the U.S. Patent Office website, but I hope to rectify that soon. I'll also be discussing this a little more in detail on Saturday. Now, in this system, the proximal anatomy, for the proximal anatomy, it's subclassified into three phenotypes based on the relative position of three objectively defined points along the center line. The key point is called the point of divergence, which is the first point moving from proximal to distal along the aorta where the diameter starts to enlarge. That is, the aortic walls begin to diverge rather than converge. The other 2 points are the lowest preserved branch vessel and the end of apposition, defined as the point where the diameter of the aorta exceeds the effective sealing diameter of the device used. For preoperative assessment, I consider that 32 millimeters. And the most favorable anatomy is when the point of divergence is distal to the lowest preserved branch vessel, which I call phenotype A. Phenotype B is when the point of divergence is proximal to the lowest preserved branch vessel, but there's still potential apposition distal to the lowest preserved branch vessel. And phenotype C is when both the point of divergence and end of apposition are proximal to the lowest preserved branch vessel. In terms of guiding therapy, I contend that phenotype A anatomy is most appropriately treated with standard EVAR. Phenotype B is most appropriately treated with VEVAR or parallel grafts. And phenotype C will most likely be appropriately treated with branch grafts when they become available, but can be treated effectively with parallel endografts if the eye of the tiger molding is performed. Now, to illustrate, consider this aneurysm. Now, using a proximal to distal approach, the point of divergence, hopefully you can see it, is right there. You can see where it starts diverging. That's an objective measurement. You can actually have a computer do it even better than you. If we're going to try to preserve both renal vessels, then the lowest preserved branch vessel is here, and there's a short segment of potential apposition distal to that. So this is a phenotype B. And I would contend is appropriate for either parallel grafts or VEVAR. Now, there were anatomic features precluding ZFEN, so in this case, the referring surgeon chose to choose parallel endografts and had an intraoperative technical success. Now, I don't have time to discuss all my rules for repair, but as I'll present on Saturday, every delayed proximal neck failure I have seen in both complex and standard EVAR has had one common feature. That is, the devices were initially implanted distal to the point of divergence. And I've yet to see a late failure when the repair was extended proximal to the point of divergence. So my target is now, in fact, the point of divergence rather than some minimum nick length. The other important rule that I will mention is that I try to avoid crossing apposition zones with parallel endografts because that removes an important defense against gutter leaks, which is why parallel grafts probably have their most value in phenotype B anatomy, because it allows you to extend the repair proximal to the point of divergence with minimal risk of gutter leak since you do not have to cross the apposition zones as in phenotype C. But this does bring in an important point, important post-repair variable for consideration. That is the starter devices, which is the fabric line, not the bare stents, and in this case is well distal to the point of divergence. Schematically, the post-deployment subphenotype looked like this, where the goal should be this. In fairness, recognize that this was performed around 6 years ago, so the referring surgeon hadn't heard this talk yet. But notice that despite the relatively low started devices, there is still no gutter leak. Again, this is because he chose the right anatomy. Phenotype Bs have a very low incidence of gutter leak as long as the device is sized and positioned so that it will achieve some infrarenal apposition. Still, in retrospect, the started devices is distal to the point of divergence, and the patient presented with proximal neck failure and had a kinked occluded left renal stent 27 months later. So both the initial success and a late failure are predictable if you use the point of reference system. Oops. For treatment, we simply extended proximal to the point of divergence using parallel endografts in the remaining 3 renal visceral vessels. And in summary, the point of reference system can be used to improve patient selection and guide therapy for aortic aneurysms. For durability, the goal of therapy should be to extend the repair proximal to the point of divergence, and parallel endografts likely have their best value in phenotype B anatomy by allowing for improved durability with minimal risk of gutter leak. Thank you.